whether these are planned events or whether these are spontaneous events, to help organizers hold these in a way that can minimize the risk for COVID-19 and for other infectious diseases. And some of the considerations that need to be taken into account to help those organizers, whether they're planned or spontaneous, takes into account what is the disease, the virus circulation in that area. Is it an area of active transmission? Is there a way in which people can remain physically distanced? They can be at least a meter apart. Should they be wearing a fabric mask when they're out? And is there a way to quickly be able to detect cases and monitor those cases if someone is sick? It is important that anyone attending an event, whatever event that may be, that if they're unwell, they stay home. And if they are in a place where they cannot maintain physical distancing, to wear a fabric mask to prevent the potential onward transmission. But any opportunity where people are in crowded places and the virus is present and the appropriate measures are not put in place, the virus can take hold, the virus can transmit. So it's important that we put in measures so that these gatherings can take place safely.
Thank you very much for this. Next question goes to Kyodo News Agency. We have Tomo online. Hello, Tomo. Can you unmute yourself, please? Let's try one more time with Kyodo. Do we have Tomo online? If not, we may come back to Tomo from Kyoto. Now we'll go to BMJ, and we have Jonathan Owen. Jonathan, please unmute yourself, Jonathan.
Good afternoon.
Yes.
With the situation in Beijing, just wondered if you could tell me, are there any plans to mobilize any medical teams to assist, and could we be seeing the start of a second wave there in Beijing? Is that a concern?
I think, as we've seen in many countries, the emergence of new clusters, especially when the origin of the cluster or the driver of the cluster is not recognised, is always a concern. But what we do like to see is an immediate response to that and a comprehensive set of measures. In other parts of the world where we've seen that approach of really investigating thoroughly, testing, isolating and quarantining cases or quarantining contacts, it has generally led to containment of the clusters, be they around religious communities, around markets, around other migrant dormitories and many other environments in which this has occurred. However, Beijing is a large city and a very dynamic and connected city, so there's always a concern. And I think you can see that level of concern in the response of the Chinese authorities. So we are tracking that very closely. Our country office, and remember, we do have a team in China that's actually based in Beijing. Our country office there is led by our country representative, Dr. Gauden Galea, and we have a number of epidemiologists permanently embedded in our Chinese office and work on a day-to-day basis with colleagues at the National Health Commission, at the China CDC, and at CDCs all around China. We have offered further assistance and further support as it is needed, and we may be supplementing our country office team with more expertise in the coming days as the investigation develops, and are working directly with colleagues again at China CDC on some of the more important findings like genetic sequencing and other investigations that will be important to understand the origin and spread of this disease. Ria?
Yeah, I just want to highlight, not particularly on Beijing, but in all countries, that have had some success at suppressing transmission, have been able to reduce transmission to a low level or eliminate it. All countries need to remain at the ready. And so it's very important that countries have the systems in place to be able to quickly identify any suspect cases and test those cases and follow the same pattern of events that need to happen. Make sure we test, isolate, trace contacts, quarantine contacts, so that any resurgence can be picked up quickly and can be stamped out. And I think that's an important message. It relates to even the first question about, where is the epicenter? In some respects, all countries need to be prepared to be that epicenter and to prevent the possibility of becoming the next place where cases can resurge. We know from the data from our seroprevalence studies that a large proportion of the population remains susceptible. So all countries need to be on alert, and Beijing has activated their systems. We've seen similar situations with Singapore, with Japan, with Germany, with many countries. And so it's just important that everybody remains at the ready to be able to quickly detect and care for those patients and do contact tracing appropriately.
Thank you. We will go now to Simon Ateba from Today News Africa in Washington. Simon?
Yeah, thank you for taking my question. My name is Simon Ateba from Today News Africa. I know that Dr. Tedros and some senior UN officials signed a statement at the weekend condemning racism. And I just wanted to know what WHO is doing to fight racism within the WHO, and also when it comes to testing and everything related to COVID-19. Thank you.
So thank you very much. It's true, as you have said, I have joined my colleagues, UN senior officials who are, from our continent, to express our voice, to condemn racism and any form of discrimination. As you know, racism and any form of discrimination should not be tolerated. And it's through addressing these two problems, actually, we can bring peace and stability to the world. So that's why we raised our voices for equality. So all human beings are treated equally. Then coming to what we do in WHO, it's the same. I think what we do in WHO cannot be different from what can be done elsewhere. Racism and any form of discrimination should be condemned and should be fought. And we need our position. I think last week during our presser, I have already indicated or clarified WHO's position. WHO's position is for equality, and we will do everything to make sure that this happens in WHO and everywhere as members of the global community. Thank you.
Thank you, Dr. Tedros. We'll go now to AFP. We have Agnes Pedrero. Agnes, if you unmute yourself, we will be able to hear you.
Yes, hello. Do you hear me?
Yes.
Yes, hi. Thank you for taking the questions, even if I think it was partly answered. But I wanted to ask you what level of concern you have with the fresh cluster of cases in Beijing. And when you talked about the more than 300 cases, did you include any deaths inside? And about the investigation, is it done by the Chinese authorities or someone else? Thank you.
Maria will speak. I don't believe any deaths have been reported in association with the disease, and as is normal, sovereign countries investigate and respond to epidemics on their territory and request assistance from WHO as needed. We are always, and in every case when there's an epidemic or a new epidemic in countries, we always offer assistance, technical, operational and logistic as needed. In this particular case, and I think in the case of this response, I think Chinese authorities, as many countries around the world, again, like Korea, like Japan, like so many other countries, have learned many lessons in the last 6 months in how to handle COVID all over the world, and I think have built significant capacity in doing that. However, we will continue to monitor the situation, continue to offer that assistance and continue to make information available to the international community as we do for all other countries. Maria?
Yeah. Case numbers, it was over 100 cases that we reported as part of the cluster. But just to say about, are we concerned? We're always concerned for clusters. You know, in every country, in any country, wherever we hear of a clustering of cases, I mean, first and foremost, I should say every single case of COVID-19 is significant, and every single case needs to be followed up and cared for appropriately. But clusters are a special condition, because in any country, we need to understand, why is there the clustering? What brought these cases together? Is it related to an expat dormitory? Is it related to a healthcare facility? Is it related to a long-term care facility or a school, or whatever it may be? Because that will help us understand it and bring it under control. So any cluster raises our concern, as it does in all countries. And as Mike has said, we've seen officials take this seriously and do a proper investigation, as we are seeing in other countries that are seeing these cases. We are witnessing many countries apply the fundamentals of public health, of outbreak investigation, which public health professionals are trained to do, to find cases, to understand the extent of infection by doing active testing, and to follow up on all of the cases and contacts and care for anyone that is ill. My understanding is that there are no deaths associated so far, but of course, as Mike has said, we will monitor the situation as we do in all countries.
Further add, I think obviously these events are a threat in their own right, and no one likes to see them, but they do offer opportunities to understand disease transmission and to understand the circumstances and the context and the behaviours in which disease transmits more readily. And I would point you to, we've had some excellent articles come out in the last couple of days, one in the MMWR from the CDC in Atlanta, from Feroz and et al., Japanese colleagues who've done extensive cluster-based investigations looking for specific risk factors and specific situations and behaviours and contexts in which transmission has been generated in clusters. That's what we need to know. We need to have our scientists around the world investigating clusters, seeing what's driving infection. We have a lot of speculation around what's driving infection, what's causing this, what's causing that, and that's important. It's important for us to hypothesize. It's important for us to make models about what might be happening. But the answers lie in careful, systematic, exhaustive investigation of disease clusters to really look at what is happening in these situations and then what is causing amplification of disease in the human context. And if we get that, we will build up a much better picture of the public health advice we need to give our communities on what behaviours to avoid, on what places to avoid, on what circumstances to avoid, and for us in public health to have better policies to guide governments. So I do think this is an important issue, in as much as it demonstrates that rapid response to contain clusters and systematic, thorough investigation of those clusters is both a public health act to stop the disease, but an act of public health discovery to understand how this disease transmits in these circumstances.
Next question comes from Pian, who works with the National Public Radio. Pian?
Hi, thanks for taking my question. I was wondering if you could clarify the remarks earlier about flu. It sounded like Tedros was saying that COVID is making it harder to plan for flu because the surveillance systems are down, but shouldn't we be doing a better job looking for flu because we're screening so many people for COVID, and also a better job combating it because we're taking precautions against COVID, which spreads like the flu?
Just maybe I can begin and Renji come in. I think what we need to do here is, first of all, foremost, recognise the contribution that our influenza surveillance colleagues have made all over the world. I think we got ahead very much in doing surveillance and testing for COVID-19 because we had such a strong infrastructure around the world for flu surveillance. But what has happened, and this is quite understandable, as countries have fought COVID-19, a lot of the resources that are within the flu network have been not inappropriately, but entirely appropriately pushed into COVID surveillance. We now need to find that balance to ensure that we're also able to track influenza properly during that same period. We're now entering a period in the world where we have to be able to track both COVID-19 and influenza. Both are dangerous pathogens. We're lucky in influenza. We have vaccines that can seriously reduce infection and reduce severity of disease. And in order to be able to use those tools most effectively, we need the right vaccines. And in order to have the right vaccines, we need the surveillance data to tell us what the circulating strains are. And the work that Wenjing here will speak and her team do with our collaborating centres all around the world is a vital, more than 50-year programme that has done just that. We need to continue to invest in that programme, and now we need to be able to use those surveillance programmes to do both surveillance of COVID and influenza. This is exceptionally important for the coming months, especially in the Southern Hemisphere. Wenjing?
Yeah, I just want to add to what Mike just said. Well, influenza surveillance has been conducting for more than half a century with contribution from more than 100 countries in the world. So this is really a very solid and highly functional foundation globally to monitor influenza outbreaks and giving recommendation twice a year about the composition that need to go into the seasonal vaccines. Now, as Dr. Tedros, Director General, mentioned that during the pandemic response, the surveillance in some countries has been disrupted, decreased, etc. So when we are entering into the Southern Hemisphere influenza season, and also it is a time to prepare for Northern Hemisphere season, where it is important where countries first need to be reminded that influenza threat is existing. There are always competing disease priorities threats, but influenza is always there. There's seasonal influenza, and also there's influenza or pandemic potential. The second is that countries really need to back to normal routine influenza surveillance, where their system in place in the country. So countries really need to optimize the use of their existing system, use the system for the COVID sentinel surveillance, and as many countries already started, also reactivate the influenza surveillance as well. The third is really to prepare for the influenza seasonal vaccination program, where we know that for influenza, we have safe and effective vaccines available, and vaccine is a main primary intervention for reduce the deaths and the disease of influenza infection.
Many thanks, Dr. Zhang. We will try to go back to our friends from Kyodo news agency from Japan. Tomo, are we more lucky now?
Yes. Yes, Terry, can you hear me?
Yes.
Thanks so much for taking my question. Dr. Tedros, a few weeks ago, you mentioned about the relationship with the United States is not only about the money, but the cooperation between WHO and the United States. But is United States still a member of WHO at this point, since we are about to have the deadline that President Trump has mentioned, the 30-day deadline this week? Thank you so much.
Thank you. Yes, the United States is still a member of a member state of the World Health Organization. Thank you.
Thank you very much. We will now go to Brazil again. We have Lara Pinheiro from Globo. Lara?
Hello, good afternoon. Thank you for taking my question. I would like to know how useful is temperature screening in public places to look for COVID patients, since some studies have already shown that fever is not always a symptom of the infection. Thank you.
So thank you for your question. I will begin. You've almost answered your question with your question, in the sense that many people ultimately will have a fever, but not all people present with a fever. There are many ways in which people can be screened. Temperature screening is one, but there are a package of measures that need to be put in place to identify cases. And so, as we have pointed out, it is very important that there are systems in place that cases who are suspect cases, if you're feeling unwell, you stay home and you contact your medical provider. Suspect cases are tested so we know if they are indeed a case or not. And I will again highlight influenza here. If you have respiratory symptoms or you're feeling unwell, not only looking for COVID-19, but also looking for influenza, especially in the Southern Hemisphere as the influenza season is taking off. It's important to know what people are infected with, and to follow all of the other measures that are in place. So as you mentioned, not all people will develop fever, and not all people will present with fever. Thanks.
Thank you, Dr. Van Kerkhove. We will now go to Emma Farge from Reuters. Emma?
Oh, good afternoon. Thanks for taking my question. I was wondering, given the comments from the Chinese CDC and state media this afternoon saying that they have the genome sequencing for the virus that emerged in Beijing, I was wondering, what is your message to them, given that they've said that they have this information, but they haven't shared it with the world yet? Thank you.
We fully expect that our colleagues in China will share that information. It is very important, and they have done so in the past, as have many countries, particularly in sharing the genetic sequence. The finding that this may represent a strain more commonly transmitting in Europe is important, and it may reflect human-to-human transmission more than any other hypotheses, but that remains to be seen. But we've been in close contact with our colleagues, both through our regional and country offices, but also directly, and we fully expect that China will, in the normal course, publicly put those sequences, as they have done in the past, on publicly available websites.
I would just like to add that this is a plea for all countries to share full genome sequences. We have more than 40,000 sequences that are available, and that's wonderful. But there's been more than 7 million cases worldwide, and it's important that we continue to look at the sequences that are circulating globally to make sure that we understand these viruses, and so that the networks of labs and virologists who are looking at these sequences can monitor them. So it is important that not only in China in this situation, but also all countries that continue to share the full genome sequences on publicly available websites.
Thank you. We have time for a couple of more questions, so let's try to go to China Daily. We have Chen online. Chen?
Hi, yeah, my question is also related to Beijing. I'm actually based here in Brussels, so the EU border is opening today, but countries like Germany, France still report like 300, 400 cases every day. And in the US, you have 18, 20 states have a spike, like 1,000 cases or more a day. So why make Beijing's 100 cases deserve so much attention? Is Beijing overreacting, or is acting properly? Thank you.
I think it's important to note that every country is different, and certainly in China, when you spent over 50 days without having any significant local transmission, a cluster like this is a concern, and it needs to be investigated and controlled, and that's exactly what the Chinese authorities are doing. So in that sense, it is big news, but in the great scheme of things around the number of cases per day around the world, it's not. But it is a significant event. We'll track that like we've tracked other significant clusters. Similarly, we've been concerned about clusters that have emerged in Korea or in Japan or in Singapore, and we engage very closely with those authorities to understand how they're investigating them. That doesn't mean we think the authorities are going to lose control of the situation. It's that we want to understand what the country is doing, and more importantly, what the country is learning about the origin and transmission. A separate situation is countries, for example, as you've mentioned, in Europe, who are currently exiting some lockdowns and opening up their borders. They're engaged in a careful process of lifting restrictions that is balanced with the risk of disease against the promotion of lives and livelihoods and pulling their economies back on track. And in doing that, they're measuring their lifting of restrictions with the decreases in incidence of disease. But no countries have reached that zero incidence, and that's a very difficult objective to reach before you exit lockdowns. In fact, that's not what was envisaged in the planning process for transitioning from lockdowns. What you need to have is sustained control over the virus and be able to get to a position where you can then safely exit lockdown while maintaining the measures like surveillance and other measures in order to sustain control of the virus. So careful opening of countries and opening of their borders with neighbouring countries is something that can be done, but again must be done in a measured, planned, stepwise fashion, with always putting in place the public health and other measures needed to be able to make up for the restrictions of movement and the restrictions of lockdowns. Thank you.
Thank you. Maybe we can go to the last question for today. We have our friend Kai Kupferschmidt from Science. Kai?
Hi, Tarek. Thank you very much for taking the question. I just wanted to ask about the status of the Solidarity trial, and in particular, the FDA has revoked its emergency use for chloroquine and hydroxychloroquine, and data just seems to be, going in the same direction. I'm just curious whether you have any news from the Solidarity trial, or when you expect to have news.
Kai, we'll get back to you on that. I believe the executive group of the Solidarity trial is meeting this week, and obviously, in the light of other data, we'll be obviously looking at the utility of continuing with certain arms of the trial based on the likelihood of finding a positive outcome. So we'll come back to you on Wednesday with an update on those deliberations and where we go from here.
Thank you very much, Dr. Ryan. We will conclude this press briefing for today. We will see you again on Wednesday, and the audio file will be sent to you shortly, and the transcript will be available tomorrow. We will also be sending you notices of press conferences that are done by our regional offices, as well as news from different places around the world where WHO has its activities on COVID-19. I wish you a very nice evening.
And as usual, thank you, Tariq, and thank you to all who have joined today, and look forward to seeing you on Wednesday. Thank you.
In December 2019, there was a cluster of pneumonia cases in the city of Wuhan in China. Some of the early cases had reported visiting or working in a seafood and live animal market in Wuhan. Investigations found that the disease was caused by a newly discovered coronavirus. The disease was subsequently named COVID-19. COVID-19 spread within China and to the rest of the world. On 30 January 2020, the World Health Organization declared the outbreak a public health emergency of international concern. In this video, we'll take a quick look at what is currently known about COVID-19. Keep in mind that this is a new disease, and what's known is rapidly evolving and might change in the future. So what is a coronavirus? Coronaviruses are a large group of viruses. They consist of a core of genetic material surrounded by a lipid envelope with protein spikes. This gives it the appearance of a crown. Crown in Latin is called corona, and that's how these viruses get their name. There are different types of coronaviruses that cause illness in animals and humans. In humans, coronaviruses can cause respiratory infections ranging from the common cold to more severe diseases. These include the severe acute respiratory syndrome coronavirus, first identified in China in 2003, the Middle East respiratory syndrome coronavirus that was first identified in Saudi Arabia in 2012, and SARS-CoV-2, the name of the virus that causes COVID-19 that was first reported in December 2019. So, where did this new virus come from? It's known that coronaviruses circulate in a range of animals. Sometimes these viruses can make the jump from animals to humans. This is called a spillover and could be due to a range of factors, such as mutations in the virus or increased contact between humans and animals. For example, MERS-CoV is known to be transmitted from camels, and SARS-CoV from civet cats. The animal reservoir of the new coronavirus is not known yet. How does the disease spread? The disease can spread from person to person through droplets, when an infected person releases those droplets through coughing, talking, or sneezing, for example, when close to another person. It can also spread when infected droplets land on objects, and when another person touches them and then touches their eyes, nose, or mouth. What are the symptoms? The incubation period, which is the time taken from exposure to the virus and development of symptoms, is on average 5 to 6 days, but can range from 1 to 14 days. There can be a range of symptoms, from very mild to severe. Some people may not develop symptoms. Common symptoms include fever, fatigue, and respiratory symptoms such as cough, sore throat, and shortness of breath. Some people reported loss of their sense of taste or smell, and some may develop a skin rash. In more severe cases, there could be pneumonia, organ failure, and sometimes death. About 80% of cases recover from the disease without needing special treatment. But there are some people who are at risk of serious illness. They include older people or people with underlying medical problems, such as chronic respiratory disease, obesity, diabetes, high blood pressure, heart disease, or cancer. How can we tell whether someone is infected? The infection is commonly diagnosed by a test called reverse transcriptase polymerase chain reaction, generally known as PCR. This test identifies the virus based on its genetic fingerprint. There's also a blood test that can check for antibodies against the virus, which may show that someone was infected in the past. How is it treated? The treatment for COVID-19 is mainly supportive care. Medicines against the virus are currently under investigation. How do we prevent transmission of the virus? There are a number of effective ways to prevent the spread of the disease. These include covering your mouth and nose when coughing or sneezing with a flexed elbow or tissue, and throwing the tissue in a closed bin immediately after use. Wash hands regularly with soap and water or an alcohol-based hand rub, maintaining at least 1 meter distance from people, and the appropriate use of masks and personal protective equipment, especially in health settings. It's important to stay home if you're feeling unwell and to call a hotline or your medical professional. But if you have a fever, cough, or difficulty breathing, seek medical care early and share your travel history or contact with someone unwell with your healthcare provider. In some areas, governments have implemented specific physical and social distancing measures to prevent the spread of the outbreak. It's important to follow their advice. Vaccines to prevent COVID-19 are currently under development, and scientists around the world are working hard to make this happen. That's a quick look at this emerging infectious disease. We're still learning about this virus every day, and what's known may change. So please, check the website below for the most up-to-date information.
World Health Organization headquarters in Geneva. My name is Alexandra Kuzmanovic from the Department of Communications, and today on Facebook, Twitter, and LinkedIn we will be talking about science and COVID-19. Therefore, it's my great pleasure to introduce our Chief Scientist, Dr. Soumya Swaminathan. Good morning.
Good morning.
Thank you for having time and taking time to talk to our social media viewers and audience. What is WHO doing on science and COVID-19? But first, would you like to explain to our viewers what is your role as a chief scientist in WHO?
Thank you, and good morning, good evening to all the viewers. As you know, the science division was created last year, so the position of chief scientist is a new one. Now, WHO, since its creation, is a science-based organization. It does normative work, which means that we develop guidelines and standards related to health for people around the world. And therefore, it's very important that this be all brought together within a science division. So basically what we do is, first of all, make sure that there's quality assurance around all of the standard setting, the normative work of the organization, which means that all the products that the different technical departments are doing are done in a standardized way, the way we collect data, the way we review it, the way we discuss with the experts and with a broader group of people, including the public. How do we do consultation? And then how do we put it together to make those recommendations? So there has to be a standard across the organization that we will enforce. And the second big area is a sort of a foresight function, is to be able to look ahead, because science is moving very rapidly. There are so many advances that are in the early stages in the laboratories today, in people's ideas and minds, that 10 years from now will impact us in a big way. So today, if we see that artificial intelligence is impacting all aspects of our life, 10 years ago we should have started thinking about this and saying, how do we prepare health systems for what will happen when artificial intelligence becomes a reality? Similarly, in genomics, there are many areas where there are such rapid advances that there will be diseases that can be cured and so on. So WHO needs to be ahead of the curve, and so that's the other major function of the science division. And so it's a very exciting area to be in, but it also requires a lot of discipline and rigor and really applying a critical lens to everything that we are doing.
Thank you, Dr. Soumya. We are also fighting COVID-19 pandemic with science. What do we mean when we say that?
So what we mean is that when you're faced with something completely new, this virus we only heard of in the beginning of January. So it's a big unknown, a big question mark. You know, where did it come from? What does it do? What effect does it have on people's bodies? What is it clinically? How does it spread? How can we control it? What drugs do we know that work? And of course, then how do we ultimately control it in the long term, say through a vaccine? So all of these are unknowns. And that is why we say that science has to bring the solutions, because you need to gather the evidence, you need to do the research, you need to, for everyone to work together to come to an agreement on some of these questions. And so really, and science has moved so rapidly, so much. We can't believe it's only less than 6 months since we heard about this virus. But we know a lot, and it's mainly through the work of thousands of scientists. When I say scientists, it also means social scientists, behavioral scientists, scientists not just the ones who are in the lab doing the work, but really in those that are in the broader area of understanding biology and natural sciences.
Thank you, Dr. Soumya. Would you explain a little bit more, how do we engage and how do we work with the scientific community during the pandemic?
So the way WHO works in general is through our wider community of experts across the world. And as I said, these span from basic scientists who work on genetics to people who do clinical work, to people who do public health work, to people who do work in ethics and social sciences. So the way we operate is through expert groups and strategic advisory committees and groups. So depending on the area of work and the topic, you put together a group of experts, and this is now done through putting out a call for experts from around the world to apply, and then there's a process of criteria that we have to shortlist people. We also have strict conflict of interest policies, so that if you're a person who's working in a particular topic and you've been funded in that area, you have to declare that you've received funding for that area of work and from whom have you received funding. And then there's a committee that looks to see if that is fine for you to come and still be part of this committee, and then you declare your conflicts of interest. So we have hundreds of these expert groups that advise us, And the secretariat, there are experts within WHO, of course, in all these technical areas, but they don't make the final decisions. The decisions are made through these expert committees who look at all the evidence, who study it, and then who advise. A good example I can give you is the SAGE, the Strategic Advisory Group on Immunizations. And they actually are the ones who make immunization policy for the whole world. And everyone, all countries follow that, and many of the agencies like Gavi, the Vaccine Alliance, they base their procurement of vaccines on the recommendations of SAGE. So that's just one example, but we have many committees like that actually develop these guidelines.
Thank you, Dr. Soumya. I would just like to use the opportunity to invite our viewers to ask questions about science and COVID-19 on Facebook and LinkedIn through comment section. And if you're watching us on Twitter, please use the hashtag AskWHO. You mentioned immunization, and in February, WHO gathered hundreds of scientists around the world to discuss a research and development plan for a vaccine against COVID-19. So what was the plan they agreed on?
So in February, we had something called the Research and Innovation Forum for COVID, and this was again a few weeks after we heard about this virus. So what we did was bring together over 400 people from around the world, again scientists, experts, clinical, from all areas, but related to research on this virus. Many people connected virtually because they couldn't come physically to Geneva. And we developed 9 working groups. So one of them was on vaccines, but there were 9 working groups looking at all of these different aspects of this virus and the disease that I mentioned. And each one of them actually produced a document on what do we know about this area. And of course, there was less known and much more that was unknown. What are the important questions that we need to answer in order to, for us to control this? And they developed a roadmap. So we developed a research roadmap that covered 9 different areas related to the virus. And so these working groups that were developed in January and worked through the February forum and till now have all made progress. So what we're doing is at the end of this month, on June 29th and 30th, we reconvene this, probably more scientists now, not 400, but maybe 1,000 people, to discuss what have we learned in the last 4 months, what are the big knowledge gaps that we now have much more information on, what are the remaining big topics that we need to work towards. So we hope that we take stock and then we look forward again to the next 6 months on what are the priorities we need to work on. Now specifically on the vaccines, I think everybody is interested in knowing about vaccines. What we did at that time, early January, February, was okay, scientists are going to be coming up with vaccine candidates. What is it going to take, for something in a lab to actually get to becoming an injection that people can receive? And there are many steps, many steps. It's not easy. Vaccine development normally takes 10 to 20 years. So here we're talking about developing a vaccine in 12 to 18 months. But we have to be sure each step of the way that we establish that this vaccine actually works, which we call it efficacy, which means that it protects against infection, and safety. These are the 2 properties of the vaccine. It should be safe in the sense you do not want a vaccine to cause more problems than what it's supposed to protect against. And so you have to go through these different phases of testing, starting from the laboratory, from cell cultures, then you go into animals, mice, and some larger animals like monkeys. Then you go into humans in a small number of people, what we call a phase 1 trial, where about 20 or 30 people or 50 at the most are given this injection. Sometimes different doses are tried, and you look at them very carefully over the first few weeks to see what happens, both in terms of an immune response, because you want a good immune response to the virus, but also any side effects. Then you go to a phase 2, which is usually several hundred people. Again, you're looking at the immune response, you're looking at safety, you start looking a little bit at efficacy, and then you do a phase 3 trial, which is usually thousands and thousands of people, where you have 2 groups. One group gets the vaccine, the other group gets usually some other vaccine as a standard or a placebo injection, and then you wait and watch over a few months for people to develop COVID through natural exposure. And then you see how many people developed in the vaccine group, how many developed it in the placebo or the standard group, and also you are looking at side effects. Then you come to a conclusion on whether the vaccine is having protection and also safe, efficacious and safe. And then there are criteria by which you judge that. And that's where policy bodies like the SAGE on immunization will come in, because they will then look at all of this information and say, yes, this vaccine passes the test and can be recommended. And sometimes there are caveats. You cannot give some vaccine to elderly because it doesn't have a good response. Some vaccines cannot or should not be used in children till they are properly tested in children. So pregnancy is another one where we have to be very careful and make sure the vaccine doesn't cause damage to the fetus. So these are all the different aspects which need to be looked at. And so, as I said, normally this takes minimum of a few years, 4 or 5 years, but because we're in the middle of a pandemic, we are trying to compress this timeline, but at the same time not compromising on any of the scientific principles that I mentioned.
Thank you very much, Dr. Sumia. And a lot of our viewers are already asking, even though you explained the whole process that we need to go through to develop a safe and effective vaccine, they're still asking when can we expect a vaccine against COVID. And at the moment we have over 200,000 candidate vaccines, right? 200. So do we know if any of these is in advanced process at the moment of a trial?
Yes, and it's true, everyone is waiting for a vaccine because it's clear that a vaccine would be the best way out of this pandemic. If you can vaccinate enough people, let's say 50-60% of people become immune, the virus can stop spreading from one person to another. Now you can get immunity through natural infection, but we've seen now in many countries where there's been a lot of infection that even at the end of a big outbreak, you have only 5 to 10% of the population with antibodies. So it's clear now that through natural infection, it's going to take a very, very long time to get natural herd immunity. So we need a vaccine. Now, what's the soonest we can get? As I said, we're hoping through doing everything in parallel, instead of doing one step after another, which is the normal process of vaccine development, we try to do overlapping. You're already planning the manufacturing while you're still doing the clinical testing. You're overlapping phase 1 and 2, phase 2 and 3. But the minimum it takes about 12 months, 12 to 18 months. The good thing is that some groups started working in January as soon as the genetic sequence of this virus became public. And so in March, we actually had the first vaccine candidate being tested in human beings, the phase 1 test. Now there are 2 vaccines that are currently in the later stages of testing, phase 2, phase 3. So we are expecting some results by October, November, December of this year. Now we cannot predict at this stage if either of those 2 vaccines is going to meet those standards that I talked about. But if we are hopeful and optimistic, yes, we could have the results at the end of the year, and we could also have some doses available. Now, how many million doses are going to be available? We cannot say. But the good thing is that we have another 8 or 10 candidates which are getting into human trials, and again, which will be in large scale human trials by the end of this year. So we're going to have 10, 12 candidates entering or completing some part of human trials, and therefore we can be very hopeful that in 2021 that we will have at least 1, if not more, candidates which are shown to be safe and effective. And you remember that it's not enough to show safe and effective, then you have to manufacture hundreds of millions of doses. So the other thing that WHO is working on is this developing a allocation framework, because we don't want to be in a situation where there are some doses of vaccine, but that they're not available to everyone, that they're just available to a few people in a few countries. So this is where the global solidarity comes in, and our member states are discussing, how do we make a fair and equitable allocation, so that, let's say you have 50 million doses to begin with, who are the people who need it the most? It shouldn't be limited by country, but it should be Is it the most vulnerable, the frontline workers that we see are getting infected? Is it the elderly, people above 60 or 65? We need to have a consensus on that so that we agree to share the virus, the vaccine that's available. The virus has been shared by all around the world. So now we need to share the vaccine also in a way that we protect the most vulnerable. And as we go into 2021, 22, we'll have hundreds of millions, and many companies are saying they will manufacture billions of doses. Then it becomes easier to distribute it more fairly.
But WHO as well launched an initiative to work with countries and partners to ensure access to vaccine once it's developed, right?
Yes.
Could you tell us more how we are doing and collaborating with countries in this initiative?
So there are two initiatives which are linked but a little different. One, what we call the COVID Technology Access Platform, which is an initiative that was launched by the Director General and the President of Costa Rica and about 35 other heads of state about 2 weeks ago, to basically ask countries and research funders and companies to deposit their technology into this access pool, which means that you then make it available to the public as a public good. And some people have described, for example, a people's vaccine, which means you develop it, but then you donate the technology, you donate the intellectual property so that everyone can use it, many companies can use it. The other initiative that we're leading and we're working really hard on is called the ACT Accelerator. So that's it's ACT stands for Access to COVID Technologies again, Accelerator. It's basically how do we bring everyone together, private sector, public sector, funders, multilateral agencies, the UN, and scientists to develop these tools, diagnostics, drugs, and vaccines for COVID, and do it in an accelerated time frame as soon as possible. And it starts with access. So it's not just about the research and the development, but it's how do you get access to people? How do you make sure that we can deploy it in all countries? So that accelerator is really a wonderful way of all partners coming together to see how do we do this. And a part of that is also how you invest in these tools. You do public pooling, you do risk pooling. So if all countries invest in a whole range of vaccines, then there's a better chance for every country to have a winning candidate. It's like a race. If you bet on one horse and that horse doesn't win, then you're left with nothing. But if you're able to pool your resources and bet on 6 horses, one of those 6 has a much better chance of winning. And this is where I think the public needs to understand, politicians, countries need to really come together and say, how do we, this is a global problem, so it has to be a global solution. And in this case, a national solution will not work for very long.
Thank you, Dr. Sumia. We are receiving some very interesting questions, and here is the first one from Carolyn Rayleigh, saying New Zealand doesn't have any more cases of infection, I believe. So why are you still thinking the rest of the world needs a vaccination?
That's an excellent question. And I think New Zealand and a few other countries have been able to show that by applying the standard and well-tested public health measures, that they've actually been able to cut the transmission down to practically zero. And as I said, there are other countries who've shown this is possible. There's Vietnam, there's South Korea, there's Germany, there's Taiwan. There are countries and areas that have shown that this is possible. Within larger countries also, some areas have shown it's possible, but many places are struggling. And so I think while this question raises the important point that what do we have now? We have diagnostics, we know how to do contact tracing, we know how to do syndromic surveillance, identify people who have the symptoms, to be able to isolate them. We need to find their contacts and quarantine them, and the public needs to follow the things that have been shown to work, maintaining physical distance, wearing a mask when you go out, covering your face, and ensuring that you're doing your hand washing and respiratory etiquette, not coughing and sneezing in public, staying home if you're sick. If everyone followed all of this, I think we could bring down infection rates in many countries. But I think in the long term, New Zealand opens up its borders, it will have infection coming in because it's spread all over the world now, and people cannot remain in isolation, and therefore you need a vaccine. so that we can go back and start the economies up again as quickly as possible.
Thank you, Dr. Soumya. Here is another question related to vaccine development, and our viewer is saying that my country has started for a clinical test phase 1. The vaccine is imported from another country. What do you think about that? Can it work? Because we know the strain from every country is different. The mutation of COVID-19 is very high.
That's another excellent question. Luckily for us, the mutations that have been observed, and all viruses mutate, they change, so that's expected. But the mutations have not been shown to be in those regions of the virus, the spike protein, the receptor binding domain, that are going to alter the efficacy of a vaccine so far. So viruses keep on changing, and we have to keep an eye on that. But the other interesting point that this question has raised is it okay to do a vaccine trial in one country and then have it applicable to all countries? Based on the science now, yes, we think so, because the virus may be slightly different, but it's not so different that the vaccine will not work. But it's also good to have vaccine trials in many different countries, because you have different populations, different genetics, different risk factors, and so it is a good, and WHO would very much like to see the candidates that are being developed now being tested in many countries, like we're doing the Solidarity trial for medicines. The other advantage of that is that we have seen this epidemic up and down in different parts of the world, right? So you have a Europe wave that subsides, then you have the North American wave, you have a Latin American, a South Asian. So if you have trials happening in different parts of the world, it's much more likely that you will have places where there's still active transmission of the infection going on. So you can answer the questions, you can finish the trials faster if you are set up in different parts of the world, because if you're doing it in one country and the infection is controlled, like we mentioned New Zealand, but also China, for example, you won't have enough infection. So the trial will not be able to be successful, because you can't compare the two groups that we talked about earlier. So that's another reason, and I think it's a very good point that's been brought up, to have these global trials.
Thank you, Dr. Soumya. Here's another question. You touched base on that already, but maybe to explain more. How will, the question is coming from LinkedIn, and thank you. How will the vaccine be tailored for the population where a large range of biological factors might interfere with the effectiveness of the vaccine between individuals? For example, different health conditions, age, different lifestyles, environment exposure.
Yes, excellent questions. So this is why you need these phase 3 trials, which are large. I said they're usually in tens of thousands of people, so that you get a mix of all of these factors you mentioned. Age, sex, other diseases, conditions. Age is extremely important because old age and young have different immune responses. The elderly don't respond as well to certain kinds of vaccines. And for this COVID, we have a range of different vaccine platforms. So there are some which are traditionally being used in many different vaccines, like we know that inactivated viruses, where you kill a whole virus and use it as a very old method of vaccination. Then you have whole but attenuated viruses. They're still living, but they have less virulence. Then you have protein. You just take a part of the viral protein and you use that with an adjuvant. But now we have new platforms which are DNA and RNA viruses, which have never been used in people before. They've been developed for other diseases, but never used on a wider scale. So here it's exciting because you have the advantages of some platforms which can be manufactured in large amounts and used, like the RNA vaccines. But on the other hand, we don't know how it will actually turn out when we test. So it's exactly to have this kind of information in different populations, different risk groups, different age groups, male, female, etc., that we need to do these large phase 3 trials. And it's a big undertaking. It's not very simple. And here again, that's why we need collaboration. We need countries to come forward to take part in trials. You need companies to come forward and say, we offer our vaccine for testing in many places. And you need well-trained teams. And you also need the local communities to be engaged and understand. So it's all of you, it's the communities that should ask questions, that should participate in the decision making. And every country that wants to do clinical trials this is the time to start doing those preparations, having those dialogues with people who will eventually be the volunteers, with the regulatory agencies in the countries, with the ethics committees, with the doctors who are going to be leading these trials. So we need all of this to happen now before we start having these big trials in the second half of this year.
Thank you, Dr. Sumia. Here's the next question coming from Salish Bastola. What technological research are going on for faster and more accurate virus detection?
That's again, it's an excellent point. And as everyone knows, right now for the virus detection, you need to take a specimen from the respiratory tract through a nasopharyngeal swab, and then you need to take it away to the lab in a medium, and then you extract the RNA of the virus, and then you detect it. It needs a pretty sophisticated lab environment and trained people and machines. What we would like is a diagnostic test that could be rapid, easy to do. Any health worker can do it, low risk, so that you're not coughing and things like that onto the person, and you can get the result in half an hour. So what we call a rapid detection test. We have this for other diseases like other respiratory infections. Even for influenza, there's a rapid test. You go to the doctor, they take a swab, you wait, half an hour later you have a test. For streptococcal sore throat, we have the same thing. That's what we need, where scientists are working on a rapid antigen test which could be used on a respiratory, and if it can be self-done by a person at home, that would be even easier, because then you don't go into a health center and expose yourself or expose others. So that's one area of work, and we don't have one yet, but hopefully we will. The other one is, can we use saliva or can we use an oral swab, instead of putting the swab to the back of the throat. So again, people could do it themselves and drop it off at a testing center. And then in the test center itself, there are innovations like pooled testing. If you have a shortage of kits and you want to test more people in the community, you could pool 5 or 10 samples and then do the PCR test. And if it's positive, then you have to test individual samples. But if it's negative, all those 10 people were negative. So you've actually saved on many kits, because we know that shortage of kits in many countries is affecting how many tests they can do. But so diagnostics is an extremely important area of research.
Thank you, Dr. Sumia. Let's talk a little bit about treatment. We know that at the moment there is no treatment for COVID-19, but WHO launched an international solidarity trial to help finding an effective treatment. So how does this trial work?
So before I talk about the trial, let me just say that while there's no specific treatment for the virus, we know what we have to do to treat people. And again, you see countries who've done it well have very low case fatality rates. So it's not, we don't need to give up that we don't have a treatment. What we need to do is to diagnose people early, which means again you have to do more of case finding. You have to go out in the community and test people, everyone who has symptoms. Finding people early and keeping them under observation is a very good way of reducing mortality, because then you know how they're progressing, and if there's any sign that their oxygen levels are dropping or that they are becoming breathless, they need medical care. Oxygen is extremely important. So all health facilities that look after COVID patients must ensure that there's oxygen. There's a lot we've learned about the nursing of these people and how to look after them, when to use ventilation, when not to use ventilation, what are the other supportive drugs that seem to be helping. So there's all this clinical management, which again we're putting out guidelines on and updating them. But then of course we would like to have a drug that works specifically against this virus. Antiviral drug discovery is again not a very easy task. So what we started off by doing, what scientists started off by doing, is looking at existing drugs which are already used for other diseases, and then seeing if we can repurpose them. So quickly do lab tests to see whether the existing drugs are active against this virus in the lab, and then take those into phase 3 clinical trials, because you've already established the safety of that drug for some other disease. It's being used in human beings. So it's called repurposing. So the Solidarity trial that the WHO started and many other trials around the world were basically testing these other drugs. So we've got, in our trial, we've got lopinavir ritonavir, which is used for HIV treatment. We've got hydroxychloroquine, which of course is used for malaria, but also for other autoimmune diseases. We've got a drug called interferon. Interferons are also used as stimulants of the immune system. They've been used against MERS, another coronavirus, for example. Then we've got remdesivir. This is a drug that's not been widely used. It was developed and tested for Ebola, and it was shown to have antiviral effect against SARS-CoV-2. So these are the 4 drugs that we are testing within the Solidarity trial, and other trials are also using the same drugs. And the idea was, again, to do it in a large number of patients around the world and to use this drug, these drugs against a standard of care, which is your control against which you will compare. And currently we have about 4,000 patients enrolled in about 18 countries, in over 450 hospitals. So this is a huge collaboration across the world. Every continent is involved. Latin America, in Africa, in Asia, in the Middle East, in Europe. And so we will have ultimately, hopefully, good answers on whether these work or don't work. Now, because these are repurposed drugs, they were not specifically developed for this virus, there's a chance that they may not work, but it's worth testing them and trying them. And meanwhile, of course, scientists are coming up with more, we're keeping an eye, so we keep on updating our landscape document to see what's new. And the next set of drugs which go into Solidarity may be monoclonal antibodies. It could be other drugs that people are finding are effective. So we've established the platform now, and all of these doctors across the world are excited and wanting to continue this type of exercise. So once we finish testing one lot of drugs, we can take another set.
Dr. Soumya, how can countries join the trial, and can individuals volunteer to be part of a trial if their country is part of it as well?
So the way it works is that WHO, of course, put out a call, and we received, in fact, over 100 countries we received expressions of interest. So what we do is then we follow up with the Ministry of Health. We have to sign an agreement that we work together, and the Ministry of Health must agree to co-sponsor the trial. Then they actually appoint one leading doctor in the country to be the coordinator, and that doctor then identifies the hospitals where COVID patients are being admitted. They have to go through the ethics approval and the regulatory approval from the country. Then we ship the drugs, and then they start